We're ready to roll? Testing. Okay. Um, First of all, I want to thank you all for coming out on a Saturday morning to listen to this lecture. I just want to first start by thanking Alex Stetch, who is Greendale's event lead. She is awesome at getting these organized, getting the food, and working with the lecturer to get everything squared away. So thank you, Alex. Also, I just want to talk real briefly before we get to Dr. Trister about Greenale Physical Therapy. This clinic, particularly, we used to be across the street at a 3,000 square foot facility. We outgrew that space. We moved the primary location across the street to this facility, 5,000 square feet. I am super biased, but I think this is the nicest facility in central Massachusetts. But we also started across the street in the older facility, Neurological Balance and Vestibular Center. So that is the first of its kind in central Massachusetts, and that has really taken off. Also, I've handed out some stuff on a future lecture by our occupational therapist, Nick. There's a lot of confusion on what OT and PT does. Hopefully he's going to dispel that. And also if you have hand, wrist, elbow, or shoulder issues, might be a good lecture to attend. Also, any providers that are here that are interested in doing a lecture, they just contact Alex after the lecture. She can line it up. We will promote it via social media, faxes, emails. So even if people don't show up, they're still getting that information and you're getting exposed to people. So there's that as well. Also, I'm going to ask Greendale therapists, I'm going to enlist you guys for some services and students just to help us clean up afterwards, if you don't mind. That would be super helpful for Alex so she's not doing it all herself. And also the last thing I had was Greendale has been super successful over the past few years. We're seeing thousands of patients a year, and we're almost overrun with patients, which is a real good thing. I didn't have that problem when I started back in my 600 square foot facility, but we are looking for therapists. So anybody that knows a physical therapist or physical therapy assistant, we're looking for a per diem, part-time, and full-time therapists to join our awesome team. We have an awesome team of therapists. We have great outcomes, great patient satisfaction scores. We're hopefully a good place for people to practice. We work really hard at that. So without further ado, I'm going to introduce Dr. Jon Trister. Also, before I introduce Dr. Trister, I want to briefly recognize his daughter, Dr. Diana Trister, who actually started a recent practice in Northborough doing direct primary care. And if people aren't familiar with direct primary care, it's a subscription-based service where you pay a fee on a monthly basis, and you get a lot of easier access to your primary care versus waiting months and months to see your regular primary care. So if you're interested in direct primary care, Dr. Diana Trister is over there. So, Dr. Trister. Dr. Trister is a distinguished physician whose career spans nearly 5 decades in 2 continents. He graduated from medical school in Ukraine, then part of the former USSR. In 1975, he went on to complete his residency training in both general surgery and orthopedic surgery. His expertise deepened through fellowship training in the renowned Ilazarov Clinic in Siberia, Russia, where he specialized in management of complex injuries, musculoskeletal trauma, bone defects, and chronic infections. In 1990, Dr. Trister immigrated to the United States, where he completed his residency in internal medicine at St. Vincent's in Worcester, followed by his fellowship training in spinal cord injury medicine at Harvard Medical School. By 1996, he had established his private practice in Worcester, where he's been serving the community ever since. Since 1999, Dr. Trister has focused his practice on orthopedic medicine, treating musculoskeletal problems with innovative non-surgical approaches. His areas of expertise include prolotherapy, orthopedic manipulative therapy, platelet-rich plasma PRP, and regenerative techniques that activate mesenchymal cells using autologous blood. So some really cool stuff. From 2011 to 2013, he served as president of the American Association of Orthopedic Medicine, and has been an active member of the Hackett-Henwell Foundation, advancing education and training in regenerative therapies worldwide. Today, Dr. Trister continues his work at his private practice in Worcester, where he's dedicated to helping patients overcome and restore function through cutting-edge, non-surgical orthopedic care. He also works in collaboration with Dr. Jon Trister. Please join me in welcoming Dr. Trister.
Thank you.
Okay.
Thank you for introduction. A lot of things to say, and I try to put as much as possible in this 1 hour lecture. So I will jump from one place to another place. So this will not be strict PowerPoint presentation. And so the prolotherapy is a stimulated ligamental repair. Stimulated ligamental repair using injection technique and delivering solutions, so various solutions which irritate area of the ligaments at the site of attachment, these ligaments to the bone. This site of attachment called enthesis. Enthesis, this is a place where when tendons and ligaments and capsule attach to the bone, enthesis. And you see sometimes terminology enthesopathy. Enthesopathy, this is exactly disease of enthesis. Enthesopathy could be inflammatory, in rheumatoid arthritis, for instance, or could be traumatic or overuse injury or consequences of sport injury, etc. And the prolotherapy was developed in the United States by George Hackett. In 1938, he was Ohio industrial surgeon. He worked as a surgeon in Ohio, and he developed this excellent technique, and he published a book in 1938, which called Ligamental Relaxation and Treatment. And he achieved great results. After that, he shared his expertise and knowledge with Gus Hamwell. And Gus Hamwell was a unique physician who trained many physicians in the world and traveled all around the world in Caribbean, Nicaragua, Honduras, and trained many physicians. One of them was Jeff Patterson. And I'm lucky to be the student of Jeff Patterson in relation to prolotherapy. So a grandchild of George Hackett, if we can say that. No, and Diana probably grandchild. Okay, so the concept of prolotherapy is, paradigm of the prolotherapy is the tensegrity. Tension and integrity. Tensegrity is the structural arrangement of the connective tissue, bones, and muscles to hold body together. Traditional view of the musculoskeletal system, we know there is this skeleton, and we think that to the skeleton we have muscles and tendons which attach to the skeleton. This is the function of the skeleton. It's quite different from tensegrity paradigm. Bones actually stretched in the forces of elastic forces of the muscles and tendons and ligaments. So they hold this together. So the term tensegrity was coined by Buckminster Fuller, American architect, who created geodesic dome. Everybody probably saw about this geodesic dome. And another architect, Kenneth Snelson. And they developed concept of tensegrity. And this is what it is. This is concept. This is just metaphor, how our body is built. It's not how our body built really, but this is metaphor of these things. So you can assume that this is the bones, and this is ligaments, and this is ligaments and everything, okay? So this is called tensegrity. And this specific structure called icosahedron. Icosahedron, just simple, icosahedron. And I kept this in my office since 2000, and everything was great. And but with time, humidity, temperature, and everything, this elasticity of these rubber bands changed. And Dr. Diana Trister asked me, why don't you build another one, new one? So I built new one. And the old one, which I built in 2000, now become like this. And this is relatively new. They're about 22 years difference between two of them. So various factors affected this structure, because this structure was the same like that. Rachel, do you remember this? Yeah, the same. The same happened with human. As a result of chronic injuries, aging, different diseases, we develop changes and disintegration of tensegrity. Disintegration of tensegrity. And if you look on this tensegrity model, this is what this tensegrity does. Nothing changed. Form remained the same. And this is what happens as we get old. Pardon me? It's depressing. So the goal of therapy, the whole concept of the prolotherapy, is it possible to rebuild and restore this tensegrity which we lost as a result of chronic injury or something else, or diseases and everything? So this is a whole about prolotherapy, how we do prolotherapy. And I have a lecture about biotensegrity, what you see here, for about 2 hours presentation. And I'm trying to give you just in a few words, what are these things. For instance, I'll give you one thing, will be very interesting for you. So this is a model of the pelvis, model of the pelvis. And we know this is the sacrum, this is ilia, correct? And we know the sacrum is suspended between the ilia. This is system of suspension. Somebody will argue with you, oh, there is no motion in this SI joint. It's not true. If no motion in SI joint will not exist. It will be just simple one single bone. That's it. The same with the foot. Same with the foot. Why have 26 bones on the foot? 26 bones. On the wrist we have 27. Here are 26. Because this is help us to arrange, to make sure that our body able to tolerate, able to function in a different environment. Like this structure, which as you can see, this structure didn't change at all. So the prolotherapy is attempt to restore connective tissue insufficiency, to rebuild laxity of the ligaments. And we treat ligaments. We treat ligaments attachment to the bones. We treat ligaments attachment to the capsules. We treat capsules attached to the bone joint and cartilages. I have this model here, this hip joint, okay, hip joint. 182 pounds right now. Every time I walk and I put 182 pounds on my hip, 182, 182, 182. And this 182 pounds go into my hip, it go to my knees, and go to the ankles, so everywhere in the body. If you buy similar bone in the butcher store and you put your thumb on a cartilage, you will easily destroy this cartilage. You will develop indentation in the cartilage with much smaller force than 182 pounds. How is this possible? It's possible because the forces of connective tissue, tensile forces of the ligaments, tendons, and muscle which cross over this joint, as well as entire body, support and maintain that pelvic, the acetabulum, does not touch normally the femoral head, does not. It's suspended. We do not touch this. Only when this system of suspension failed, when this failed system, then we start to touch, acetabulum start to contact the femoral head and gradually develop destruction of the cartilage. And this leads to arthritis. So this is just example on the hip joint, but similar thing occurs in everywhere, in the disc area, facet joint area, SI joint, and everything. So muscles play important role in prevention of these things. And eccentric contraction of the muscles is very important to consider in conjunction when we do physical therapy for our patient, how we do this. Let's say I will take this chair and I show you how elderly people sit down. Okay. And how young people sit down. So this is fail of eccentric contraction. Now, did you see people walking like that? You probably see more than I see this. When I step on this leg, In order to do this nice and slowly, my contralateral gluteus medius must act upon and prevent rapid descent on my right side. Correct? With me? So it's not that just only weight destroys the joint, but rapid stop destroys the joint. If you take a boxer glove and hit the wall, will be one effect. But without glove, with the same forces, will be different. You will hurt. Because with the glove, your stop will be slower than without. Because elasticity of the glove will prevent rapid stop. So the same with this sitting here, prevent my ischial tuberosity, my SI joint, lumbosacral area from rapid deterioration, correct? So the same with everywhere, hip, knee, and everything. So that's why in the physical therapy, in my opinion, in our treatment after prolotherapy, it's very important to educate people. Let's say somebody has a knee arthritis, not only focus on the exercises on the knee, but how to train and make a stronger contralateral gluteus medius muscle. So this is the point what I like to make. And let's go over, okay. Then, so what we do with the prolotherapy? Prolotherapy, this is a system of injection, as I said to you before. We inject 15% of dextrose mixed with lidocaine and normal saline, so the total concentration will be 15%. 15% of dextrose is hyperosmolar compared to our body osmolarity. Our body osmolarity is 0.9%, and osmolarity of the dextrose is 15%. When 15% of dextrose will be around the area with 0.9% osmolarity, the fluid from 0.9 will move outside and cell will be dead. So this dead cell, which I induce, because prolotherapy actually is a controlled injury. I create an injury, we prolotherapists, we create an injury in the fibro-osseous junctions, in the enthesis. We create an injury with a needle. Injury number 1, delivering 15% of dextrose number 2, extravasation of the blood, small bruises in the area of injection 3, activation of mesenchymal stem cells, which are present in every place in our body, occur, and this activate inflammatory-like reaction, which lead to healing of the pre-existing injury. This is what prolotherapy is about. It's not injection for pain. It does not relieve your pain right away. This is attempt to restore and to rebuild the normal connection, to rebuild and restore tensegrity, to approximate femur from the tibia, tibia from the thallus, to stabilize shoulder joint, to make sure that in the glenoid fossa, your shoulder moves nicely and strongly, and keep it in the center, because if the humerus does not hold in the center position, then excess of motion is occur, specifically superior translation of the humerus, which will start to hit against the acromion. And what is between acromion and the humeral head? Supraspinatus. Supraspinatus. Why was it so commonly injured supraspinatus? Because it's exactly located between it's okay. Between acromion and humeral head, and attached to the tubercle in the humerus. And this is where we inject. And this supraspinatus is continued to the muscle belly with the spinal scapula, correct? This is spinal scapula, and this is supraspinatus, and this end on the medial angle of the scapula, There is another muscles immediately started here, will be levator scapula, and levator scapula go to the neck, to the transfer processes of the C3, C4, C5. It's not surprised why people with shoulder pain may sometimes have the pain in the neck, because all of these tensile forces which act up in this area transmitted to the neck. People may come to your neck and doctors will order MRI of the neck. Definitely, in 90% of the cases, find some disc problem, which is not necessarily the cause of the issue. So, but this is what potentially could happen. So the ability of physicians to diagnose correctly the problem is the key. Luke was so kind to agree to be a model. If you look, come here, please. Sit down here. Because we just talk now about shoulder, I'll show you a few things. So we should talk not about just glenohumeral joint. We should talk about shoulder complex. And shoulder complex consists of several joints. Number one is the sternoclavicular joint. Number two, acromioclavicular joint. Number three, glenohumeral joint. And number four, scapular rhythm, scapulothoracic rhythm. So when we check the shoulder complex, we must pay attention to all of these structures, how they function. Because sometimes people come to me and say, oh, I do very well with the shoulder. Wait. There's no motion in the glenohumeral joint. There's a motion in the scapula. He moves the scapula. So we must be able to see this. So for physical therapists, I want to show how I approach, in Diana, how we approach examination of the shoulder. So I'll ask Luke to do internal rotation, and I will do resistance. Just do this. Okay. So this is a function of the subscapularis muscle. So I do resistance. If you're able to overcome my resistance, subscapularis muscle doing very well. Okay. The next motion I would like to check is supraspinatus. Supraspinatus does that motion, but in conjunction with deltoid muscle. Separate, the supraspinatus do only superior translation. Actually, deltoid muscle do superior translation, but together they will do abduction. So we'll just do this. And I check if patient able to do this, number one, and if patient experience any pain in this chain of the muscles and attachment, which potential can cause a problem. Then I ask Luke to do this external rotation, and this will be teres minor muscle, okay? Okay, move, excuse me. Okay, and infraspinatus, two muscles, infraspinatus and teres minor do external rotation. Then I ask him to stand up, please, and I stand behind him, and I palpate the lower angle of the scapula, and I ask him to do abduction and observe how his scapula start to move. So normally scapula start to move approximately in 15 degrees of abduction. Just start to move. Just do this. Oh, okay, it start to move. If I feel that the scapula moving right away, it means the problem is in the glenohumeral joint. So he start to compensate using this. So my treatment will be focused with the prolotherapy, not only just to inject here, but also how to do something here, how to activate serratus anterior muscle, which glide the scapula forward, correct? Okay. And here in the front, what we need to palpate, nicely careful, is the coracoid process. Everybody able to palpate coracoid process? Just put your arm in the position and supination, external rotation, and immediately to smaller tuberosity, you palpate this structure here. Is it palpate? Everybody capable to do this? Okay. Hold this like this, okay, and slightly walk slowly in the lateral direction. So the first structure after the coracoid process will be lesser tuberosity. Palpate. Do you have pain here? Oh, yes. Okay, this is subscapularis. Hold on. Walk next. Will be bicipital groove, which is the biceps goes, correct? So go next. Greater tuberosity, supraspinatus attachment. Okay? To more this better, ask patient to put the arm behind and palpate just immediately below the acromion, and will be the facet with the attachment of the supraspinatus is occurs. This is a key. As far as you possibly, the women very often come to stand and say, I cannot put my bra on. All right, so this is one of the functions. They cannot do this. And immediately here, go above, and on the top, it will be acromioclavicular joint, AC joint. They all working together in the motion of the shoulder complex. They all work together, and all could be affected. It's not just some. Why coracoid process is very important? Coracoid process is like a hub in Atlanta airport where all airline company flying, because here in the coracoid process, multiple ligaments, tendons, and muscles attached to. So even in just simple injection of the prolotherapy in the coracoid process will do great job. Another thing, from this coracoid process, two important ligaments go to the clavicle. One is called deltoid conoid ligament, and another called trapezoid ligament. And they go around the clavicle like a hook. They hold the clavicle on acromion. So the problem with the acromioclavicular joint is not just acromioclavicular joint, but the laxity of these two ligaments which are running from the coracoid process to the clavicle. It's clear? Okay. So deltoid muscles attached here. Remember this? Very often people who have shoulder problem, they come to, I have a pain right here at night. I have a pain here at night. Why is that? Because gravity pulling down the arm. Supraspinatus doesn't hold. Capsules doesn't hold anymore humerus. And the deltoid is stretched. And the site of attachment become very painful. Okay. Next, we're moving down to the elbow. Move down to the elbow. Don't worry.
No, I'm saying I already had surgery on the elbow.
Okay, we'll do this.
No, it's fine. It's healed now. I tore the ligament.
Okay, great,
Yeah,
excellent,
there you
great.
go.
Excellent.
Even better.
Okay, so now in the elbow area, there is tennis elbow and golfer elbow, lateral epicondylitis, medial epicondylitis, inflammation, put ice, heat, ibuprofen, blah blah blah. We know this. I'm not here for that. I want you to carefully palpate radial head. So to palpate radial head, put your two fingers, like I put two fingers above his radial head, and ask patient to do supination, pronation. Two fingers like this. So your head should be between two, okay? Two. And on the top of this radial head is annular ulnar ligament, which hold ulna, radius on ulna, which hold on ulna. If we put this here, you do excellent job, thank you. So this is a radius. So this is ulna. And this is ligament, which hold like this. On the top of the ligament, there is a muscle which called supinator muscle. And supinator muscle has two bellies. One is a superficial and another is a deep. And between these two bellies, there is deep branch of the radial nerve coming, this radial nerve. Annular ligament oppose effect of the biceps. The biceps flex your elbow and does supination. This is a function of the biceps. Supination and flexion. And it's attached to the radius, to the same bone which hold the biannular ligament. So this is conflict between strength of the biceps femoris, biceps brachii, and annular ligament, which is trying to pull the ligament from the elbow. When this happens, ligaments become weak and loose, and then muscles try to help. And the supinator muscle, which on the top right here, go into spasm and squeeze the deep branch of the radial nerve, which causes numbness radiating down to the arm. So you see these people. So our focus as a prolotherapist, so we need to inject to treat annular ligament to make it stronger, and ask physical therapists to work with the patient to do reciprocal inhibition of the biceps by activating triceps muscle to assist us to healing the annular ligament. It's clear? Stop me if I need more questions. Yes?
Would those injections on the arm work if your shoulder is a replaced shoulder?
No.
It won't work.
No. Question was, will it work if the shoulder people have total shoulder replacement? No. One of the rules in the prolotherapy is do not inject where metal is present. We don't inject where the metal is present. Absolutely not. Injection goes against the bone, and specifically when ligaments and tendons attach to the bone and capsules. Nothing else. We never inject in the presence of the metal in the area. We never inject if the patient has infection. We never do this. So this is example of the lateral epicondylitis. On the medial side, this medial epicondyle, or slightly above the radial annular ligament, we have attachment of the extensors muscles, which go to the wrist, do extension, correct? And in the medial aspect, we have a flexor, which go down to the arm. And one of this very important muscle called flexor carpi ulnaris, which attach to the pisiform bone, here, pisiform bone. As you remember, on the wrist, we have 8 bones: scaphoid, lunatum, tracheatum, pisiforme, hamatum, capitatum, trapezoidum, trapezium. 8 bones. And we have flexor retinaculum between the flexor retinaculum. And this flexor retinaculum, tightness of the flexor retinaculum, controlled by flexor carpi ulnaris. Now you will understand why is this here. Okay, scaphoid, lunatum, triquetrum, pisiforme. Between each of these bones, we have ligaments which go connect them. Each bone is connected. If you look on your arm, you will see it look like an arch. This is arch. This is normal. Arch must be present, the arch. So this is this arch. And palmar transfer ligament goes here. So this space here called carpal tunnel. This is a carpal tunnel here. And here we have 9 tendons and nerve, median nerve, right here. What happened? When ligamental laxity of the transfer ligament occur and laxity of these ligaments which connect each individual bone happen, the channel become, carpal tunnel become flat like this. So assume this is the bones, and this is transverse ligament, and all of the structure go into this place, all right? And it's become flat and start to compress median nerve inside the carpal tunnel. And people come to the office, my office and your office, and tell, you know what, I have carpal tunnel. I want to have a surgery. What are your symptoms? You know what, I wake up at night and my 3 fingers, thumb, index, and middle finger, numb. But then I stand up and I shake my hands and I feel better. This is one of the symptoms of the thing. So what happened? In a horizontal position, you have distance like this, and the gravity pulling your bone against your nerves and against your tendons and against the ligament. And as soon as you change gravity direction, when you stand up, gravity changes, your symptoms disappear. So the goal of prolotherapy, how to restore and rebuild this space from that to get like this. Then you free the structures which coming inside the carpal tunnel. Here's gentleman, what's your name? Ed? Ed. Ed 2 weeks ago had injection of the PRP, platelet-rich plasma. He has a trigger finger, middle finger, no, ring finger. And he's still in the process of recovery. And he asked me, is the prolotherapy work for trigger fingers? Yes. Is the cortisone work for trigger finger? Yes, too. So this is fingers. This is distal finger, middle, and this is distal middle portion phalanx and proximal phalanx, and this is metacarpal bone. And we have the tendon which running inside this channel. And this channel made by connective tissue consists of cruciform ligaments and annual, pulley, it's called pulley, annular pulley and cruciform pulley. If you look in the anatomy textbook, you will see C1, A1, C2, A2. So A, annular pulley, C, cruciform pulley. So this arrangement of this pulley created tunnels, like a tunnels where the tendons must glide nicely and easy. So the treatment in the prolotherapy, we inject with the tiny needles, we inject in attachment of this cruciform ligament and attachment to the bone here, here, and here, and here, and here. This leads to shrinking these ligaments, then become more shorter and restore the channel when the tendons goes. So, and this is the end of the treatment. This is how we treat trigger fingers with prolotherapy. How we treat carpal tunnel syndrome with the prolotherapy. Our goal is how to rebuild and restore this space. We inject here, inject here, inject here. And because of fibers of connective tissue have a different direction. One goes here, another goes here, third here. So we don't know where they go. But this non-specific treatment will activate all of these fibers and they find their own way how to stretch. And by doing this, they restore normal architecture, normal form. And normal form lead to restoration of the function. Form and function not separable. Absolutely not separable. You can see this not only in the musculoskeletal system, you see this in the physiology of the human body. For instance, let's go to chest wall. Ribs, costochondritis. Is people coming for costochondritis for physical therapy? Not very. Okay, so the costochondritis, this is a kind of disorder of the connection of the cartilage, which connect to the sternum, and cartilage, which connect to the rib. The rib has the two parts. Rib has the bony parts, and this rib has cartilaginous parts. An inflammatory process may occur in a costochondral junction and in a chondrosternal junction. Very often we see this, of course, after bypass surgery on the heart, open heart surgery, when surgeon must cut the area to save the patient's life. So this is what leads to these things. Normally, when we do inspiration, the ribs, this is my ribs, for instance, ribs go like this. This is motion of the ribs. And this motion occurs in the 4 places. Costochondral junction here, chondrosternal junction, costochondral junction, and on the back, there's the 2 junctions, costotransfer junction and costovertebral junction. Costovertebral, this is the only place we cannot inject because it's too deep and dangerous. But the rest, we can inject. All right? So when the ribs do not move properly, this will affect the diaphragm. The diaphragm, this is a muscle which separates chest cavity from the abdominal cavity. And the heart and the lungs inside the chest cavity. And the heart is not just simply hanging around like in a space. Heart has a connection to the it's yours. All right. So this is a chest cavity, and this is a diaphragm, and this is heart, all right? And in the lateral view will be like that, the spine here, vertebral body, and here will be sternum, here will be diaphragm, and here will be heart. So the heart has a multiple connection, ligamental connection to the sternum, here, 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 and powerful pericardio-diaphragmal ligaments. If your chest wall motion is incorrect and the ribs do not moving well, and diaphragmal breathing is abnormal, and you probably work with diaphragmatic breathing, so this will lead to abnormal contraction of the heart. The heart normally, when diaphragm goes down, heart elongate and twist. This is what heart does. It does. If this is not work properly, it's meant to lead to different abnormality in the heart, especially heart rhythms, palpitations, may induce atrial fibrillation or different arrhythmias. If you palpate xiphoid process, everybody know what is xiphoid process? The end of the sternum, correct. So palpate xiphoid process, because here in the front you have muscle attached with this abdominis, rectus abdominis, but on the inner aspect, diaphragm. How often you see in the men after age of 50 ventral hernia? Almost all have ventral hernia. How to detect? So just ask patient to lay down and sit up, and you see bulge here. This is ventral hernia. Ventral hernia. Women don't have this. Why? Because women have a pelvis. So everything goes, extra abdominal pressure go to the pelvic area. And women will have organ prolapse, incontinence, and everything. So men will have more gastric reflux, women will have more prolapse. And so this is the same process, just the abdominal pressure must go somewhere, either there or here, or gastric reflux. This will be the same thing. Now let's go to musculoskeletal. Continue, yes? Okay. Disc disease. Yes, disc disease is very important consequences of the deterioration of the tensegrity. It is. But this disease, in my opinion, does not develop by itself right away. It's developed as a consequences of multiple other factors which lead to these things. And I think ligamental laxity of the anterior longitudinal ligament, posterior longitudinal ligament, supraspinous ligaments, yellow ligaments, lead to abnormality. And very important muscle here, which stabilize the structure of the back, is called thoracodorsal fascia. Thoracodorsal fascia, this is right here, is attached to the iliac crest or iliac crest, and give a raise of the latissimus dorsi muscle also. And slightly deeper will be iliocostalis muscles, then will be quadratus lumborum muscle, and a deeper layer will be also psoas muscle, correct? Psoas muscle. And all of this muscle create the posterior aspect of the back area, and this very, very tender. And I know I speak to many, many doctors who do musculoskeletal problem. Almost no one checked attachment of the thoracodorsal fascia to iliac crest. I'd like to show how to do this. Can you sit down, please, facing the wall there? So I always ask patient to bend forward slightly, and you palpate the edge of the ilium. And this is on the edge of the ilium, you will be able to feel the pain here, all right? And then you continue to palpate, you palpate SI joint, you palpate anterior, posterior, superior iliac spine, all right? PSIS, everybody know how to palpate PSIS? Okay, PSIS, palpate your PSIS. And then it's very important when you examine that to do neurological exam. Turn around, please. You do neurological exam to check L4, L5, which will be knee reflexes, L5S1 will be ankle reflexes. You look at the atrophy of the muscles and everything. And you certainly will have a limited range of motion in the back and everything. One is a very important test, what I usually do is a Trendelenburg sign. Do you know how to do Trendelenburg sign? I'll show you. Stand up, please. Oh, I think I have here. Just stay here. When you see twisting of the arm, and the one arm become longer than another one. So this is also another example of rotoscoliosis. And this is what it is. So I was in one museum and I saw this picture. It was in the Czech Republic. And you see this lady here in the middle. She stands on the left leg and her right buttocks dropping down. It's positive Trendelenburg. And this is, do you see that? Yes. So the normal, correct? Those who know, It should go. Oh, it should go opposite. Yes. So this, I find this is very interesting. So turn on both sides. So I will remove this not to irritate people. All right. All right. Sit down, please. Here. So how would check Trendelenburg sign? Turn around, please. I palpate PSIS, and then I ask patient. Well, he's a strong man. He can do this without. Just put this in front. Okay. Just slightly touch the chair in order not to fall. Just to keep it in balance. And now, please raise your right leg up. So you expect that PSIS on the right side will go up. Put down. Hold this again. Raise your left leg. It shall go up, if normal. If it goes down, it indicates contralateral weakness of the gluteus medius. Then after that, what you do, you need to check attachment of the gluteus medius on the ilium, number 1, and then the greater trochanter, number 2. How to do this? Lay down, please. On the side facing me. So I ask patient to lay down on the side and bend knee and put the foot behind the knee like this. So this creates a deduction of the leg, and then the greater trochanter become more prominent, and you can palpate greater trochanter. And I usually put my 3 fingers, one in the front of greater trochanter, rather on the back, and one in the middle. So, and if I need to inject this area, I take a needle and I go with the needle to inject very tip of the greater trochanter, and then I slowly redirect needle and go down toward the entire hip joint from the lateral approach. We'll not talk about the injection technique, but this is how to palpate greater trochanter. The best way to do this in that position. And if people come to you, I have a back pain here, just do that. Because if you do this in that position, you'll be unable to palpate greater trochanter, but only in the abduction. Sometimes you need to put this even down like this and palpate like this, okay? Is it painful?
No.
Not yet, not yet, okay. Okay, sit down, please, sit down. Now, so the hip joint, I will not tell you how to examine the hip joint. You do external rotation, internal rotation, you do various testings to see if patient, but by the time people come to you, you already know that there is already a diagnosis of osteoarthritis of the hip or something else, correct? So one thing I'd like you to point to you, how to examine the knee. So the people come to you, put your leg here. As you know, rotation on the knee, on the rotation of the tibia on the femur is impossible when your leg is extended. It's impossible. In order to rotate tibia on the femur, you need to flex 90 degrees and then ask patient to do external rotation of the foot. I want you, all of you, put your leg down, 90 degrees flexion, put in a neutral position, put your fingers on the top of the tibia, so you'll palpate tibia from the top. Now do external rotation. You see how tibia move forward? Yes? Why is so important? Because when you in that position, you'll be able to palpate edges of the meniscus. These palpate edges of the meniscus. Now, keep like this, each your knee, okay? And very gentle pressure, like this. Very minimal, just 2 grams. And palpate the tension tissue and go medially along the tibia, go medially, and at some point, do external rotation again. Look, external rotation, palpate the tibia, and then slowly press very little. And you see resistance, and then you reach more resistance. When you reach this more resistance, try to do this. It is very good. It will be beginning of the MCL, medial collateral ligament. All right, continue to go next, and you will see the end. So this is the end of the medial collateral ligament. And you go more, and you will feel here semimembranosus muscle attachment or a part of the hamstrings, and semitendinosus in the front, correct? And the biceps femoris on the fibular head, which is the three muscles which attach to the ischial tuberosity and make a hamstring muscle. What is interesting about these muscles is very important. A lot of people may develop semimembranosus bursitis, which sometimes confused with popliteal effusion, with popliteal cyst. This is two different things. Popliteal effusion, this is extension of the knee joint capsule in the popliteal area. Contrary to this Baker cyst, by this definition, this is cyst and attachment of the semimembranosus muscle to the posterior medial aspect of the tibia. So this is two different things, and usually smaller than real popliteal effusion. But everybody calls it Baker cyst. Okay. All right. Semitendinosus muscle here in front. Sartorius muscle go from here to here, and gracilis muscle go from pubis bone to here. They create pes anserinus bursitis. You see this all the time, correct? Which anserinus bursitis also come together with venous stagnation. When people have varicose vein, venous insufficiency, exactly in the same area you will have the problem in the pain. When you see a patient who comes with you with this pain and swelling, and you see varicose vein, one may consider, what is this? Is it really semitendinosus or pes anserinus bursitis, or this is could be congestion of the venous insufficiency? Then the biceps femoris attached to the fibula, fibular head, and it's coming from the ischial tuberosity, correct? And the ischial tuberosity also site of attachment of the sacrotuberous ligament. Sacrotuberous ligament, this is ligament which go from the sacrum to the ischial tuberosity. And this sacrotuberous ligament control nutation of the pelvis. Everybody know what is a nutation? Nutation is a movement of the sacrum base forward, called nutation. Movement of the sacral base forward, called nutation. Movement sacral base opposite, called contranutation. And this motion occurs on the level of S3 sacral vertebra. Nutation, contranutation. Nutation, contranutation. So sacrotuberous ligaments which attached here on the edge of the sacrum and go to ischial tuberosity, controlled also by biceps femoris. So biceps femoris fibers cross this area and also participate in the controlling of the movement of the sacrum. And this continues to the fibula. And then this end on the fibula. And what other muscles start on the fibular head? Peroneus longus. Peroneus longus goes down and attached to the base of the first metatarsal bone, crossing foot on the bottom, correct? And then peroneus brevis attached to the here. So all of these muscles, doctor who does prolotherapy must know all of the things. In a daily practice, it's not just prepared today for this talk, no. In a daily practice, this is our routine. This is what we're doing with the prolotherapy. It's not just simple injection of the sugar with the hope this will help. We analyze what should be injected, what is deficiency, what is the laxity of the ligaments, how laxity in one place contribute to another laxity. And I'll give you an example. Let's say people come to you with, let's say, tibialis posterior tendinitis. Tibialis posterior tendinitis, you palpate here, you palpate the swelling behind medial malleolus, and you start to treat, hit. So what else? Yeah. Somebody, like doctors, will inject corticosteroids. Yes, okay. But tibialis posterior attached to the navicular bone and cuneiform bone 1, 2, 3, medial, median, and lateral, and it support spring ligament called calcaneonavicular ligament and calcaneocuboidal ligament. This ligament on the foot which maintain the arch. When these ligaments become weak, the posterior tibialis trying to help them and go into contraction to maintain the arch of the foot. And this leads to overwork and muscle become inflamed, and you see tibialis posterior tenosynovitis here. The problem is here. But manifestation, clinical manifestation will be primary, will be here. But if you know about this phenomenon, you palpate the distal attachment of the tibialis posterior on the navicular bone, and you, oh, it's painful. And when the foot completely collapses eventually, and people develop pes plana, valgus deformity, it will lead to stretching of the medial collateral ligament, which create more compression on the lateral aspect of the knee. It will create more compression on the crural joint, when the tibia will be affected by thallus because everything will shift to the right. People start to work like this. Internal rotation of the hips develop. Hyperlordosis is developed. Contraction of the latissimus dorsi develop. A latissimus dorsi, what does? Internal rotation. And you see the patient who comes to your office like this with a hyperpronation. So this is what is tensegrity and the prolotherapy. I'm glad to answer your questions.
You ready to ask questions?
Yes.
Does anybody have questions for the doctor? Ooh, ready. Where it's like causing some sort of, it sounds like trauma to the area with the injection, is there like a recommended downtime that you're suggesting? Like 24 hours? Like where you're saying the integration of PT, is there like a specific timeline?
After trauma.
After the prolotherapy, like how long would they have to wait to resume like movement to affected area?
Good, very good question. So we usually recommend keep it easier for 1 or 2 weeks.
Okay.
Let it heal, because we create inflammatory process, we create some injury. If we start to irritate this area right away, it will be counterproductive. Imagine the tree you plant in the soil, and very next day you try to exercise this tree. It will be counterproductive.
What's the function of the sugar that you inject?
We inject, it doesn't matter. You can inject everything you want. Sugar is just safest material, and we utilize this osmotic gradient, osmotic concentration.
Okay.
Old knee injuries that had several surgeries and it's bone on bone now. Would your injections help with that?
Okay. It depends on the clinical examination. For instance, if somebody has, let's say, knee arthroplasty without any metal and shows evidence of knee instability, and it will be good evidence of this patient will be successful in the prolotherapy. However, if patient has effusion in the knee, it usually indicates more advanced arthritis, which develop as a result of the injury or disease, and results could not be as promising as I speak. And because when in the prolotherapy, physician must deliver to the patient clear answer. Will he get better or not? This is the key. The doctor must establish good relationship with the patient, because we work together, and we not try to get more prolotherapy, we try to help, because we know if we help, we become more patients. But if we see that we will be unsuccessful, we tell, sorry, it's not our case.
So if you have
Effusion is usually indicate more advanced arthritis, and if patient doesn't have any contraindication for surgery, and MRI confirm presence, or X-ray confirm presence of severe deterioration, reduction of the height of the cartilages, plus effusion, surgery.
What would contraindications be then for
For
the
prolotherapy?
Like
Excellent question. Contraindications following: active infection, osteomyelitis, cancer. However, cancer in remission, let's say somebody had the cancer on the lungs and have arthritis of the knee, is not contraindication. But cancer on the bone is a contraindication. Osteomyelitis is a contraindication. Elderly people and young people, and some, let's say, gentleman, 92 years old. He read on the internet the prolotherapy worked very well. So he comes to the office and asks me, please do a prolotherapy for me. So I examine him. This category of patients could be abused. And I always ask these elderly people come with family members. So I'll be able to explain them, all think what is going on. So the elder patient will not just jump and, oh, please do this. So we want to be ethically correct that this will not be done. The same with the kids or teenagers. I always ask, come with the parents. And the elderly come with some of your relatives. So we discuss all of the things because people must know what is the outcome, what is the prognosis, what is the chance for improvement. Not everything could be cured with prolotherapy. I just want to be sure. The selection of the patient is the key. Right selection, please. Yeah. So the stages of the healing go through the different stages. The first stage is inflammatory stage. When we inject solution, we create injury, and multiple cells, hormones, neuroendocrine systems, activation of the mesenchymal stem cells occurs in the area. This creates like a soup of different things. Then gradually, after 3-4 weeks, people develop some tissue, and this tissue start to produce pre-fibroblast and then fibroblast. And fibroblast in approximately in the 3rd week start to produce collagen, deposition of the collagen. And then toward the 6 weeks, this is maximal effect of the initial treatment as occur. At this stage, we start to do another treatment. So it's like a layer of another treatment and another treatment. It's not makes sense to do this every 2 weeks, and I explain to you why. This is, I like your question. Let me show you one thing. In my previous life, working in Russia, I work in Elizarov clinic, and there was experiment. I didn't participate in this experiment, but this literature, the article, and I have this book, and I translated this book, and I posted this book on my website. You can read about this. So Elizarov was great man. So he took dogs, series of experiments. And this is dog, front legs, back legs. And he, before experiments, he took tissue from the bone and calculate how many mesenchymal stem cells present in each bone. In the front leg was, let's say, hypothetically, 5, 3, 3. I don't remember exactly numbers, but just for simplicity. Then he did cut the bone here, experimental fraction, and put Elizarov apparatus, special apparatus, to hold this. And they check, again, biopsy in 5 days, 5 or 7 days. And he find that in this leg was about 20 mesenchymal stem cells. 2. So mesenchymal cells from all entire body migrate to this area to assist injured area to heal. When we do prolotherapy, we actually create the controlled injury. And this controlled injury activates mesenchymal cells not only locally, but from entire body. So what's not might make sense to do prolotherapy of another region, let's say shoulder, we do knee, and to do shoulder in 2 or 3 weeks, because this area will be depleted and the effect will be miserable. An optimal effect is about 5-6 weeks. People come to this empirically, but now it's scientifically proven this is what it is.
How many injections then can you receive if it's every like 6 weeks? Like, would you recommend multiple rounds then, or are you going off of like symptoms?
Okay, both. Okay. It's both. So people come, they say, unfortunately, the prolotherapy is not covered by insurances. So people need to know what to expect. People need to know how many treatments they may need. And in general, we give advice. How many treatments? Age divided by 10. This is how many sessions in general we expect to be effective. Let's say somebody is 60 years old, and I said, okay, you will need about 6 treatments, 6 weeks apart. And I always said, if you feel fine after three treatments, perfectly fine to stop. It's not mandatory to do all of these 6 treatments. It just, so that's why I say both. Yeah.
Why would you pick prolotherapy over like PRP?
Okay. Good question. First of all, we do PRP too. We do PRP, we do autologous blood, also injection. PRP is concentrated platelets. When we inject concentrated platelets, these platelets play primary role in the first 3-4 days of healing. After that, another cells participate in the healing process. This is number one. Number two, instead of injecting platelets, which require spinning, extra cost, special kit, sometimes we do prolo, and then on the end of the prolo, I take from your vein your own blood and inject your own blood exactly into the same area right away after prolotherapy session. The same day, the same procedure. So it will give more material to regrow the ligaments, more substrate for the ligaments. It's called autologous blood injection. Costs much cheaper. Your blood, and unlimited amount. When we do PRP, we have maximum 10 cc of syringe, 10 cc of PRP volume. And sometimes we need to, where to inject here or inject. I was very enthusiastic about PRP. Sometimes I do PRP, and I said, people, let's start prolotherapy, do something simple. If prolotherapy will not work, we'll jump to PRP. In my opinion, PRP equally effective, like a prolotherapy, autologous blood, in my opinion, even better. But in some cases, selective cases, PRP will be very important. I'm not saying PRP will not do this, but this is my answer. Okay, please come here. Diana, can you add something? Diana, can you add something to talk? Please come here. No, stand up. All right.
I have
Yeah.
a question.
Yes, please.
This prolotherapy, is it covered by insurance?
No.
Out of pocket expenses.
Yeah. And people ask, if this is so good, why insurance doesn't cover?
Yeah.
Yes? First of all, insurance doesn't care. Put this way. Insurance doesn't care. And I can tell you, if insurance start to cover prolotherapy, in my opinion, about 60 or 70% of orthopedic surgery will not be needed. It will collapse hospital system.
Is it like you said it was less expensive than PRP?
Oh, yes.
Yeah. Okay. So then if there was the option to do one or the other and both were beneficial, then probably doing one that was less expensive considering the patient's need
Again,
cost.
we are very sensitive in our practice, Diana and myself, we're very sensitive to money issues. This is so important because we don't want people feel that we're working for them just to get the money. It's not the case. For instance, Diana now treats my shoulder. I have much better. She did already 4 or 5 treatments. Yes, Diana? she doesn't do PRP for me. We do just simple pro. Well, she treat not only she treat my neck, my back, and everything. I also treat her neck, not neck, and not neck, not yet. knee. Yeah, wrist. So we treat each other. Her husband is a former professional hockey player, so he's a golden finding for orthopedic medicine physician. Okay, thank you.
Roughly, what does a session cost then if you have to have
No,
say, 6 sessions?
okay, so dependent on the area of the location. So for instance, say we do neck treatment, about between $500 to $600 each session. Shoulder, about 400, yes, Diana? Knee, about 400, back, about $500 each session. For some category of patient, we do discount, for instance, for veterans, and yeah, what else? Discount? Oh yes. So okay, this is very good point. When we do neck has a lot of nerve endings and sympathetic nerves, and to avoid possible hypotension, and especially if somebody has a history of the heart disease, we don't want the patient to be in a terrible situation, and when you need to put IV and the panic is not so. Prior to neck injection, we put IV line to be ready for everything. We didn't ask about complications. Why not?
Okay, what about
Okay,
complications?
all right. We'll answer to this.
Can it help mucoid degeneration like the ACL?
Yes. But again, when we do ACL, this is very tiny process in a structure. This is only small things. We need to treat entire knee plus ACL, both ends, distal ends on the tibia and the intercondyle fossa where it's attached.
Even if it is just from an injury.
We must stabilize entire joint. Oh, complication. Okay. I start with the most difficult complication. So I had in my professional life, I had one case when people develop spinal headache. So I treat a neck, and the lady developed spinal headache. This is like a leak spinal fluid because she had a history of the Ehlers-Danlos syndrome. Are you familiar with this? EDS syndrome, hypermobility syndrome. And she has some anatomical problems. And I treated her maybe 4 or 5 times. Everything was great. And on the 6th times, she developed spinal headache, which lasted 5 or 6 days. And then it was self-limited. It's go away. Bruises on the area of injection, very common. And actually having bruises is a very positive thing because you know that the blood extravasation is occur and your own blood participate in the healing process. Pain for 24, 48 hours is a normal occurrence. Any other complication? Oh, hypotension during neck. I already talked about this. The vasovagal episode.
Some people get a very dramatic inflammatory
Response, yeah.
Therapy for about 48 hours, like either they just get kind of really sick. There's so much
Inflammation.
Was that based on location?
No, in his case, not. Actually, this is one is very known doctors. I cannot say name in Worcester. He is my personal friend and everything. So I did prolo, and he had very unusual systemic response to prolotherapy. And he's probably the only one who had such a thing. Temperature, fever, chills. Oh my gosh, name it. No, he was not, but then later I realized how he had a Lyme disease, and all of his immune system was kind of crooked and inappropriately reactive to things. And actually, I did acupuncture on him. He developed the same technique, Peter. The same thing.
So would you discontinue any kind of supplements at that time, like the fish oils or the
No. Fish oil, perfectly fine. Only don't take non-steroidal anti-inflammatory. Ibuprofen, Advil, fine. Enjoy. Driving. When you come to the office for prolotherapy, first after first treatment, I advise people to have somebody to drive you home, because the effect of lidocaine could be sometimes toxic, because lidocaine is a part of the solution. And is when we do injection of the neck, is a mandatory to have somebody to drive you, because after injection of the neck, you're very stiff, and this is safety reason for driving car.
right knee and right ankle?
Yes, with a brake.
She mentioned supplements, so what are recommended supplements?
I personally like the most is the vitamin C. This vitamin C is the most known vitamin cofactor in the synthesis of the collagen. And many people deficient in vitamin C, bruises, all the things. And I recommend vitamin C, high doses, about 500, 3-4 times a day, if they tolerate, if they don't develop GI symptoms like diarrhea. But the more you take vitamin C, but dietary sources of vitamin C, in my opinion, are the best.
Thank you very much
Thank you.
for all of the information.
Thank you. Thank you.